For today's presentation, we'll discuss about clonal monocytosis of renal significance, but I have two parallel themes actually. So, hope this works. I have to click.
These could be very sluggish. Like
I have to click on it. Now it works, I checked.
Yeah.
But I have to click on it. All right. So I have two parallel themes we're going to talk about. And on the left side is our main theme. On the right side is what I'm going to talk about is okay to be wrong. Many times when we are rounding, we talk to the trainees and even including myself for my career that somehow there is a stigma about being wrong, that if you are wrong, you're not considered to be smart. So what I'm going to do is I'm going to find an objective way to demonstrate that. So this is a survey done by World Physics Journal, and they interviewed 130 leading physicists and asked them who is the smartest physicist till date. And they ranked them 1 to 10. And Einstein was ranked 1. So what I'm going to do today is I'm going to present how many times Einstein was wrong in the area of his competency. In theoretical physics, not in geopolitical or any other opinion. In theoretical physics, how many times Einstein was wrong? Ultimately trying to remove the stigma that it's okay to be wrong. All right, so we'll start with...
Okay, Shah, is this part of the well-being stuff?
Yes. Doctor, who told me about it? Please include one in the...
Very good.
All right, so this is a patient I'll start with, a clinical presentation. So this is a 77-year-old, this is a clinic patient, 77-year-old male with past medical history of primary hyperaldosteronism, FHH, familial hypocalciuric hypercalcemia, diabetes type 2, chronic kidney disease with baseline creatinine 1.5 milligram per deciliter, has a UPC of 0.6 gram per gram of creatinine, MCR of 500 milligram per gram of creatinine, and he presents to hospital with acute kidney injury and edema with anasarca. On renal presentation, his UA doesn't have any hematuria or RBC. Creatinine is 5.7. 24-hour urine protein excretion is 15 grams per day, and serum albumin is 2, meeting the criteria for nephrotic syndrome along with severe AKI. His CBC, on the other hand, has 74,000 WBC count, with monocytes being 15,000. 20%. Normal monocyte count is around 300 to 700 cells. This is 15,000 cells. Hemoglobin of 7.5 and platelet count is 57,000. So naturally, first he goes for bone marrow biopsy because there was very concerning findings in the CBC. So bone marrow biopsy confirmed the diagnosis of CMML, chronic monocytic leukemia, for this patient. But we still don't know what happens to the kidney, so definitely we go for kidney biopsy. And the kidney biopsy is, these are patients' images. If it makes it look better, on the left, you can see the light microscopy with mononuclear cell infiltration. On the right, you can see electron microscopy and diffuse food process effacement. And that is the interpretation of our pathologist. 9 gloms, severe plasma cell rich interstitial inflammation with lymphocytes, some mononuclear cells, and diffuse food process effacement, suggestion of minimal change, whatever it means for you. So, heme consult is done, and they suggest there is no indication to treat CMML unless it can be linked to his renal dysfunction, and refer to, of course, Florida cancer specialist. We are not accepting any new patients here. And this is inpatient. Of course, he gets discharged, and he comes to my clinic for follow-up. So the last point, that no indication to treat CMML unless linked to his kidney dysfunction. And that's my whole presentation about today. How can we try to connect this type of disorder with our kidney disorder, because we have a kidney biopsy report stating this. All right. So this is what my own interpretation of any hematological disease of renal significance. Whenever a nephrologist sees a patient, we do kidney biopsy. And kidney biopsy, we think it is from blood disorder. It's our opinion. Then we go to hematologist. Hematologist says there is no standard indication to treat this patient from the hematological guideline perspective. So it comes back to nephrologist. Nephrologist will go to the jar of immunosuppressant. I call it jar of immunosuppression. You pick up the medicine of your choice. We always rationalize CMI has poor side effect and MMS is better for not decreasing the GFR. If we feel steroid works for everything and rituximab, if we feel fancy, good insurance, we give rituximab. We pick one. Once we try that, there'll be some optimal response because in our heart, we know that there is some blood condition which is causing the kidney disease. So we're not going to get good response. And I thought that he's not going to get good response. So you go back to hematologist. And hematologist will tell you again that there is no indication to treat hematological disease because the guidelines in hematological literature do not recommend the treatment. And we went through this for MGRS in the past. I'm sure many of you remember the journey of MGRS. Until 2012, it was not even recognized. 2012, the International Kidney and Monoclonal Gammopathy Work Group recognized that monoclonal gammopathy of renal significance where MGUS is not undetermined or insignificant, recognizing that MGR should be recognized. And it took, of course, a couple of decades of research demonstrating that treatment is associated with better kidney outcomes. And finally, in 2021, MGRS was published as a review article in NEJM. So now, of course, after a couple of decades of research, we have confirmed that this monoclonal gammopathy, we call it renal significance, is not debatable to consider clone-directed therapy in these patients. But then it raises the question about other hematological condition. Can we move the same direction like we did for MGRS? So this is the outline of my talk today. We're going to define what is clonal monocytosis, what is clonal monocytosis of undetermined significance, what are the different clonal monocytosis associated kidney diseases, and if we treat these patients with cytoreduction, is it associated with better kidney outcomes? Now, this is a highlight of some basic background information we'll go over. So from stem cell, you have two different types of cell line, lymphoid cell line and myeloid cell line. In lymphoid cell line, if T cell, B cell, or NK cell develops malignancy, it's defined as T cell leukemia lymphoma, B cell leukemia lymphoma, which is non-Hodgkin's lymphoma, Hodgkin's lymphoma, NK cell lymphoma leukemia. But we're not going to talk about lymphoid lineage today. On the myeloid lineage, we have RBC, platelets, monocytes, neutrophil, and each is defined as essential thrombocytopenia, thrombocythemia, polycythemia vera, granulocytic leukemia, but we are only going to talk about monocytic leukemia. So we're going to talk about myeloid neoplasm and monocytic disorders associated with it. So how should one approach when they see monocytosis? Now, this is a very basic version of a monocytic approach from the hematological literature. So whenever we have monocyte count more than 500 cells per microliter with more than 10% of WBCs, or persistently for more than 4 months, it's defined as persistent monocytosis. We should exclude, of course, the secondary causes like infections. After that, they go for bone marrow biopsy. In the bone marrow biopsy, if they have ABL-BCR mutation positive, they are defined as CML, chronic myeloid leukemia. If they have more than 10 to 20% blasts, they are defined as AML, acute myeloid leukemia. In the past, it used to be only 20% blast or more, but they redefined as more than 10 to 20%. In some specific cytogenetics, even 10% blasts are considered acute myeloid leukemia. So they have to put it in context with the cytogenetics they see along with the blast count. Then, if they don't have these two, if you have features of MDS, which is myelodysplastic syndrome, where cells are dysmorphic and they have decreased cell lines, it's MDS. You can have monocytosis with it. You can have myeloproliferative neoplasm. And myeloproliferative neoplasms are essentially thrombocythemia, polycythemia vera, myelofibrosis. These are a group of disorders with a myeloproliferative neoplasm. So they are usually associated with JAK2 mutation. And you can see monocytosis with MPN. Next, we have eosinophilic neoplasm, of course, specific cytogenetics associated with this disorder. And finally, we come to CMML. The reason I went through all is because you have to exclude all of the above and have this specific cytogenetics to call this patient as CMML. And CMML is associated with profound monocytosis. And that's why I'm going to focus my talk on CMML today. But Any disorder that can cause monocytosis can cause everything we're going to talk about today. So you can have sarcoidosis with monocytosis, and you can develop the same kind of diseases we're going to talk about today. But I'm going to limit my talk to CMML because this is what is associated with profound monocytosis and majority of the disease we're going to talk about today. So in CMML, the basics about CMML before we proceed to kidney is what do we know about the treatment? Current treatment for CMML is only curative treatment is allogeneic hematopoietic stem cell transplantation. And even in those patients, the success rate is only 20 to 50%. Median age of presentation for CMML is 70 years. So many patients, less than 20% are eligible for bone marrow transplantation by the time of presentation. And at the end, only less than 5% of the patients end up going for bone marrow transplantation. So this curative option is almost not possible for more than 95% of the patients with CMML. Well, how about medical treatment? So medical treatment is hypomethylating agents, which are 5-azacitidine, also known as Vidaza, or decitabine. These are the typically used hypomethylating agents for the medical treatment of CMML. Overall response rate is 30 to 60% only. Whenever I see something has 30 to 60% response, it reminds me of amiodarone AFib. As good as it works is 50% of the time. So it's very hard to achieve complete remission. And even in complete remission, it's seen in less than 15% of the patient. It's not durable. So these patients are very difficult to control, even despite the best medical therapy available currently. And which is why these guidelines, these are 2018 guidelines in American Journal of Nephrology, they recommended permissive leukocytosis, that we should not treat patients with CMML unless they have progressive symptoms, increase in blast count, which is they're converting into acute leukemia, progressive organomegaly, or symptomatic cytopenia, especially transfusion dependency. If they are transfusion dependent, give them medical treatment, get them transfusion independent. And this kind of forms the basics of why hematologists would say we should not treat them unless there is a specific reason, because the guideline recommends, because of these reasons, that it is very difficult to treat them and we should allow them permissive leukocytosis. So clonal monocytosis becomes very common in these situations because we have CMML patients which are being observed with permissive leukocytosis. And in recent 2022 guidelines defined clonal monocytosis of undetermined significance, which is relatively new for their literature, suggesting that there are certain patients with clonal monocytosis. They can have specific cytogenetic mutation associated with monocytosis, but they do not meet the criteria for CMML. And these patients should be defined as clonal monocytosis of undetermined significance. So now we have CMML patients with permissive leukocytosis and CMUS patients with monocytosis, meaning that majority of the patients with monocytosis are being observed.
So the former entity does not have leukocytosis?
Which one?
The number one, the CMUS.
They can have all relatively same feature as CMML, which can be myeloproliferative or myelodysplastic, meaning that they can have increased cell line or decreased cell line. It can present in all forms, but they just don't meet all the criteria with specific cytogenetics, number of mutations they need to define them as CMML.
So this patient is presenting with WBC count of 74,000. So in the permissive leukocytosis, do they say like, you know, it can be up to 20,000 or it can be
like how far do you go? No, they go for symptoms.
74,000.
We'll talk more on that as the slides progress, but that's right. And that will raise a lot of questions as we talk about kidney problems. All right, this is one of the most interesting slides, or for me at least, for this presentation. And this group of investigators, what they did is they took 12 patients with CMML and they took another 12 healthy age-matched controls. And they isolated their monocytes and they performed RNA sequencing and DNA methylation to identify the different cytokines. What they are trying to demonstrate is the CMML monocytes are significantly pro-inflammatory. You can pick your favorite cytokine. This is a volcano plot. And you can pick IL-10, IL-6, CXCL2, TNF. They're significantly increased in the patients with CMML compared to the age-matched control, suggesting that CMML monocytes are very pro-inflammatory. So these patients are now living with monocytes which are pro-inflammatory. So naturally, they will have end organ damage. And this is a nice study recently published in 2021, and they demonstrated in 395 patients with CMML, multiple organ dysfunction, but the organ dysfunction is associated with higher monocyte count. So if you have higher monocyte count, presence of AKI, compared to the no presence of AKI, and then monocyte count, meaning that higher the monocyte count, more likely to have end organ damage. In addition, from our perspective, these patients, almost 34%, 35% of patients develop AKI after the diagnosis of CMML, and almost 7.5% of the patients develop new chronic kidney disease after the diagnosis of CMML, suggesting that renal involvement is very common and involvement is associated with high monocyte count. How about their prognosis? Now, they divide these patients based on, as you asked, similarly, that their WBC count. So you can have MPN form of CMML and MDS form of CMML. MPN is myeloproliferative form, where the WBC count is about 34,000. Their median survival is 19 months. Less than 34,000 count, 29 months. MDS, 42 months. Their survival is overall prognosis is very, very poor.
Sorry, for the previous slide, when you mentioned the association of different pathologic settings with the CMML, one CKD and let's say cardiovascular events, they're more easily understandable for AKI compared to this is a chronic disease. How would you think that it might be related? More than association, just because these patients have gotten AKI and they had CMML, they are related necessarily.
No, we are not claiming that. I don't think I need to claim that CMML is causing all the 35% of the AKI. All they are trying to show is organ dysfunction is very common. Now, whether these patients, compared to their age-matched control, they are more likely to get the AKI. Now, is this happening because of the cytokines they are living with? Or is it happening because of the other condition I'm going to show you? Or is it just they are making it more likely to develop AKI? I'm not sure we can claim that from the retrospective study.
Because this is, if you don't claim any form of association, it would be that a patient with CMML fell off and broke their leg also.
Yeah.
Can be on that
sure.
line.
I think that comes with a retrospective study, though, right?
So but there is some association suggested if you are putting it there.
Yeah. So I think what they're trying to claim is you're more likely to fall if you have CMML than you don't have CMML. You can make it up, right? I mean, I'm not claiming you can prove a causal relationship by a retrospective study. All they are trying to show.
We are at the level of loose association here.
Yeah.
If you do not even claim loose association, I don't see the purpose of it. You see the point?
I understand what you mean, but I think you know what I'm trying to say here.
That's fine. We say that they are pro-inflammatory.
Yes.
That it may contribute to some of the pathologic settings.
That's all they are trying to say. Again, not my paper.
No,
they are just trying to
but there is
claim.
no mention of any kind of infection, malignancy, or anything in this slide, right?
No.
Which is more associated with cytokines pro-inflammatory states.
At long run.
Right? No, liver dysfunction, CV event. It's difficult to
They are
get
not
a connection
matching
with
them for
right, but
other pro-inflammatory conditions,
so
if that's your question.
exactly.
Correct.
Autoimmune conditions,
Correct.
infection, malignancies.
Correct.
It does not show in this.
No.
Right.
I hope it's not published in any journal.
So sorry, Dr.
Leukemia reviews.
Sorry, Dr. Shah. This is outside. They are trying to get the audio.
Is that
Audio is on.
Okay. Sorry.
Is it not moving green? It's
is that
moving
what the
green.
chat is saying?
Can't hear. I'm not loud enough.
No, it says you're talking, right?
Yeah. Okay. Moving on. So background in summary. Summarizing the background. Okay, I'll try to move a little faster. So CMML is profound monocytosis. Clonal monocytes are pro-inflammatory. Permissive leukocytosis is a common practice. Kidney involvement is common. Not sure it's caused by it or not, but it's common. And mortality is high in these patients. Now, this is the background of CMML. Before we jump into kidney, we need to learn about CMML, and that's what we were trying to do so far. All right. So we'll go back to physics about, as I promised, how many times Einstein was wrong. So this is a Bohr-Einstein debate. Now I'm trying to stay within the time limit, so I'll summarize it very quickly. So Niels Bohr and Einstein can be seen on the left figure, and he stood and published at that time in early 20s that quantum world is probabilistic, meaning that electrons and photons at the most basic level, probabilistic. If there is electron is upspin or downspin, there is no upspin or downspin until you measure it. It's all just probabilistic. And Einstein was very bothered by this theory that the universe is not deterministic. It cannot be probabilistic. So he said it famously that God does not play dice with the universe. It's not just probability. So Einstein put a theoretical thought that if you have one photon which are entangled, which means that both photons have to have a neutral spin when you measure them. So if one is upspin, other has to be downspin. Now assume there is one photon is located on Earth, and assume the second one is on Moon. And if I measure the one on Moon, I know it's upspin, so by automatically I will know the one on Moon is downspin. Now information cannot travel faster than light, then how did I know the photon on Moon is downspin? So it has to be wrong, in other words. Now, so he claimed that this is wrong. You cannot have a probabilistic quantum world. Now, this physicist gave an equation, just measure the quantum probabilities. And if it is number one, it's Bohr is right. Number two, Einstein is right. And at the end, 2022 Nobel Prize in Physics is given for proving Einstein was wrong. After years and years of experiments, meaning that the world is fundamentally probabilistic, not deterministic. All right, we'll move back to kidney. So these are all the clonal monocytosis associated kidney disorders. And I'm going to try to go the important one that I feel like we should discuss today. I will not go in each and every one. So let's start with lysozyme-induced nephropathy, which is located in the proximal tubule. So monocytes produce lysozyme. Lysozymes recruit and monocyte protein inflammation, which is recruiting more monocytes, which releases more lysozyme. Well, what is lysozyme from monocytes? It's identified in 1966. This group of investigators initially described 10 consecutive patients with CMML, and they noticed their urine has a cationic protein. And that was characteristically same as lysozyme or viramidase, and suggested that monocytes release this lysozyme. It is found in this patient's urine. It is a small molecular weight protein. That's why it's excreted in the urine. It's initially diagnosed they initially found it in 1966. Again, this is a figure from that publication in 1966 that they isolated the urine cationic protein, which is 15 kilodalton lysozyme. And you can see here that on the left, it's a cationic protein. So it's in the other extreme than albumin. Albumin is an anionic protein. So it will be on the right extreme. And this is a cationic protein in the left extreme. And they concentrated urine to see this by 20 times. And that's why they call this skilled interpretation, because if you don't, it is very trace amount to be identified without concentrating it. So this is our publication from New Age, so 2023. And you can see the cationic peak is seen in such a faint band. This is albumin band. This is a cationic protein lysozyme band, which is released by monocytes. And same way, albumin peak, and you can see other extreme, cationic peak, lysozyme peak. So it is not easy to catch on the routine electrophoresis of urine, unless it's concentrated. Now, lysozyme-associated nephropathy, what are the pathological features? So when lysozyme is, of course, filtered, gets reabsorbed in the proximal tubule, what are the pathological features we'll see is most common is intracytoplasmic inclusion bodies in the proximal tubule seen on light microscopy. You can see all inclusion bodies here. You can see all small holes, if you say. But characteristic can be seen nicely in EM. And in EM, you'll see lysosomes are significantly increased in numbers in the proximal tubules. And that suggests a clue towards lysozyme-associated nephropathy. However, final confirmation can be done by immunostaining. And if you stain them, they have intense staining for lysozyme in their proximal tubules. Otherwise, it's very hard to confirm these features just based on light microscopy, unless you perform immunostaining. Now this, on the left side, is, it's one of the very nice article published and very nice research done by French group in 2006 on MGRS. And I'm trying to correlate that with lysozyme-associated nephropathy, trying to show the proof of concept kind of study. Now, this investigation was very nice. What they did is they took the patients with smoldering myeloma who have Fanconi syndrome, and they have light chain associated proximal tubulopathy, which is crystalline form. So you can see very many crystals in the proximal tubules in these patients. Now, they isolated their light chains and they used this mouse light chain and they regenerated mouse. They made engineered transgenic mice and they replaced the mice junctional region of kappa light chain, and it was replaced by human variable and junctional region of kappa light chain. They're trying to insert the structure of human light chain into the mice and try to produce transgenic mice, and the mice produced exactly the same kind of light chain proximal tubulopathy with crystalline form. And these are the crystals seen. And on the left is a human proximal tubule crystals. And when you make the transgenic mice, on the right side, you can see the mice are making the same crystals in the proximal tubule. What they're trying to show here in proof of concept is it is only in the structure of light chain that causes the disease. It's not host, it's not environment, it's not a second hit. If you have the specific structure of light chain, you develop this specific disease. I heard another pathologist talking that in the future, possibly we'll find a way to identify different structures, and we can identify what kind of disease this patient can develop based on the structure. It is possible. And only way you can say that is because specific transgene insertion in the light chain can cause the specific type of renal disease. All right. So now, what about trying the same in lysozyme nephropathy? Now, this study was done again, 1974. And what they tried to do is they took the chloroleukemic rats. So rats have leukemia, and these rats have like a lysozyme-associated nephropathy. They isolated lysozyme from the urine of these rats, and they injected lysozyme into healthy rats into intra-aortic region. And they did it for 1 month, daily injection of lysozymes for 1 month in intra-aortic region, and it did not produce lysozyme nephropathy. What they're trying to show is just having elevated lysozyme level does not always produce lysozyme nephropathy. Possibly they need cytokines, they need the leukemia development to develop lysozyme-associated nephropathy. Again, I come back to the recent publication of all the renal pathologists where they are trying to demonstrate the clinical features of patients with lysozyme-associated nephropathy. So let's try to focus on a few salient important things. Now, this study has 37, I think, patients with biopsy confirmed lysozyme-associated nephropathy. Almost 2/3 of them were presenting as AKI or AKI on CKD. Almost 40% of them were presenting as CKD when they were biopsied. 24-hour urine protein excretion was 1.7 gram median, which makes sense. It's tubular proteinuria mainly because of the proximal tubular involvement. Nephrotic range proteinuria should be rare, so only 12% of the patients, and they may have other disease, they didn't specify. Hematuria is again rare. This is important. Features of partial Fanconi syndrome. Only 15% of the patients, 3 out of 20 patients who had the measurement available had partial Fanconi syndrome, because one would guess that if you have if you have lysosome-associated nephropathy in the proximal tubule, you should develop Fanconi syndrome, but it's not always. Now, again, that can be a caveat. It's a retrospective study. How many patients had 24-hour urine measurement, what active phosphorus they use, etc., etc. Of course, we have to take it with a grain of salt. But the point is, universal Fanconi syndrome is not common. What is most important is all of them have elevated lysozyme level. So as we mentioned, lysozyme level does not confirm lysozyme nephropathy. But if you have lysozyme nephropathy, all of them have elevated serum lysozyme level. What disease they have, underlying disease, most common is, of course, CMML. So if you have patients with lysozyme nephropathy, 40% of them had CMML. But as I mentioned in my first slide earlier, it can happen in AML, MDS, myelofibrosis. Again, all these diseases can be associated with monocytosis. So you can see some patients have AML and some have MDS, and they can still develop lysozyme-associated nephropathy. Now, there are some patients who have non-malignant disease. So as I mentioned, even sarcoidosis, if it causes monocytosis, it can cause lysozyme-associated nephropathy. One patient had leprosy. They didn't have information on 4. All right, so should we treat these patients? If we treat them with cytoreduction, if you have confirmed biopsy-confirmed lysozyme nephropathy, if we treat them with cytoreduction, what happens to them? There are only 2 published series. One was Mayo Clinic study where they had 4 patients with lysozyme nephropathy. 1 of them came off dialysis, and 4 of them have improvement in serum creatinine with median decline in creatinine by 0.3 to 1.5 milligram per deciliter. Now, whatever this means, I'm not sure what this means. Is it coming down from 5 to 4? Is it coming down from 1.5 to 1? They did not describe anything. This was a later 2 editor. So very limited information on this one. But this is a multi-center study of 29 patients with median follow-up of 8 months. So relatively more information. 1 patient came off dialysis. These are all the patients treated with cytoreduction. 1 patient came off dialysis. 6 patients have more than 15 ml improvement in GFR. 8 had less than 15 ml improvement in GFR. 1 had stable GFR. 5 had worsening GFR, and 8 patients deceased. Now, beauty is in the eye of the beholder. Now, you look at this data, whether you would like to claim that every patient with lysozyme nephropathy should be treated with cytoreduction, or they should not be treated with cytoreduction. This is the original data that it comes from. It is, in my opinion, it should be very subjective based on case, that patients should be selected based on degree of chronicity, based on their mortality risk, based on their presentation on CMML. It's possible to improve the kidney function. I think that's what we can make a
So
claim.
is there any control as well? Those who did not go through this treatment, what happened to them? Maybe all of them improved?
All of these were on dialysis?
No. These are just presenting with acute kidney injury, because this is, again, I think the same study of we used here.
Mhm.
So they have also reporting. These are all renal pathologists who have biopsy confirmed lysozyme associated nephropathy, and just looking back about how many were treated and how many were not. There is no control. There is no nothing.
These were all treated. 8 died.
I mean, CMML patients have mortality is 19 months median survival anyways. And the reason they chose to treat them, they are even worse form of those 19-month survival patients, right? Relatively speaking. So I'm guessing the reason to treat them is because they are sicker. But again, retrospective study, so. Okay, coming back to Einstein. So this was I think we are running good on time. So this was an equation Einstein gave in 1916 about gravity, that he redefined this equation of gravity, that this is how gravity should work, and he proved Newton wrong at that time. Now, his law of equations say universe is expanding. And at that time, in early 1920s and 30s, universe was assumed to be static. Because if you assume it is expanding, then it was altogether in the past. That means we are saying that there was a day without yesterday. In other words, we are saying there was a Big Bang. And that was not believable at that time. So Einstein had to correct himself. So he added cosmological constant, just added it, saying that this is additional energy that will keep everything in constant phase. So that's why universe is static. Then Edwin Hubble confirmed with his telescope that universe is actually expanding. The distant galaxies are moving faster than the closer galaxies. And then Einstein later in his life admitted that this was my biggest blunder of my life. I just added a cosmological constant, which had no reason for it.
Should I take it out?
Yeah. He didn't take it out. People took it out because it was not needed.
Necessary.
All right, moving on. So next point is renal infiltration of myelomonocytic cells. Now, again, I go back to studies from 60s and 70s, and then I come back to studies from last 5 years. The reason I go back to old studies, because I think they are very good proof of concept studies. So here, what they are trying to show in an autopsy study of 1,200 acute and chronic leukemia patients, and they divided them by decades, and this was an autopsy study. So they demonstrated what organ had infiltration of leukemia. And if you compare renal involvement in leukemias. Now, CGL means chronic myeloid leukemia. In the past, they used to call it granulocytic leukemia, and CLS. So you can see renal involvement is the most common organ being involved with leukemia. So if these patients are, again, we did not have treatment we have now. So you can see that these patients progressed with leukemia. And when they die, they almost 40% over the decades had renal involvement with leukemia. But comparatively, CLL, almost 60 to 80% of the patients have renal involvement. So CLL more frequently involves than CML, but in leukemia, it is very common to involve kidneys where leukemia will seed into the kidney. Now, if you have, this is our patient's figure, and you see the infiltrates. Now, all it says is mononuclear cell infiltrate. Now, you can identify if these are monocytes or what kind of cell it is by just morphological evidence. And depending on the phase of monocyte, you can have monoblast, promonocyte, monocyte, depending on the size of nucleus, cytoplasm. A skilled pathologist can interpret about what kind of cells they are. But in now day and age, we use the cell surface marker, which is called cluster of differentiation, and every cell has one. Based on the phase of their maturation of the monocyte, they can have different CD expression. In general, the commonly used CD expression for monocytes are CD33, 34, 14, 68, 64. And if you perform the stain, you can see infiltration will be significantly stained by that specific immunohistochemistry stain. The reason I've highlighted CD68, this is what we do here at our center. So if we ask our pathologists to stain them, they will stain them for CD68. Important thing to note is as they mature, they can have different CD expression. So if you have a monoblast or pro-monoblast, they may not have CD68. Only marker that's present uniformly in the monocytic lineage is CD163. So if you want to be 100% sure, you have to do CD163. All right, so what happens when we treat these patients? Now, this is again, isolated case report. This is just collection of case reports I have about where they found patients having infiltration of renal parenchyma with leukemia. When they were treated, what happened to them? So let's say the first case, this patient has AMML. So they have my blast phase in the CMML. It was an interesting case, so I included it here. And they found that patient had acute kidney injury, severe hypokalemia that happens from proximal tubular involvement. A lysozyme level was extremely elevated. Kidney biopsy showed leukemic infiltrates. They started them with hydroxyurea at that time with allopurinol. Patient died within 36 hours from admission. Second patient, this patient is 65-year-old with CMML, WBC count 65,000. Around 9 creatinine, extremely elevated lysozyme level. Kidney biopsy showed CMML infiltration. Patient received dialysis, chemotherapy, hydroxyurea. Kidney function improved and stabilized. No more detail was provided. Third, we have a patient with CMML who had renal hemorrhage. Actually, third and fourth, both had renal hemorrhage, and they had to go for emergency nephrectomy. These patients have MDS, so they have severely low platelet count too. So they went for nephrectomy, and that showed CMML infiltration. They were treated with therapy. Both the patients died. One died after 7 months, one died after 2 months. Again, highlighting these patients are very sick and very poor prognosis. Next one, 35,000 WBC count, renal infiltration, treated with hydroxyurea, kidney function improved. Next one, 21,000 WBC count, infiltration with monocytes, steroids, hydroxyurea, kidney function improved. So you can see they have significantly high mortality, but if you treat them, there is a possibility of improving renal function. Only case reports. That's the literature we have so far. Next will be extramedullary hematopoiesis. So kidney can serve as extramedullary hematopoiesis site. First, of course, will be liver and spleen, but after liver and spleen, it can be kidney. So you can have all trilineage hematopoiesis in the kidney, and that can cause renal dysfunction. How do we identify that? Well, to compare that from leukemic infiltration, where you will have myeloid generation cells, so you can do CD68, CD61, CD163, Staining that will tell you if it's a myeloid cells only. Comparatively, you want to see tri-lineage cells. You should have erythroid cells with glycophorin stain, and you should have megakaryocytes with CD61 stain. Now, many renal pathologists will only do CD61 stain, and if they see megakaryocytes, they will call patient has extramedullary hematopoiesis because platelets should not be generated in kidney. So, but glycophorin stain is again, these stains are not commonly used, so they are not easily available everywhere. But the point is, if you must confirm if patient has extramedullary hematopoiesis to rule out as a cause of renal involvement in CMML. Now, next point in CMML is CMML can present, as we discussed earlier, as myeloproliferative disease or MDS, or it can have both. In our patient, they had WBC count was elevated and platelet count was reduced. So he had MPN and MDS, both features. Now, if you have MPN with very high WBC count, naturally the question is, do they develop leukostasis with high WBC count in the renal capillaries? For leukostasis, this was a very nice case with a figure, so I used it for figure demonstration. You can see these patients have all the capillary lumens are filled with blasts. They are myeloid blasts. They're myeloblasts. And myeloblast can cause capillary lumen occlusion and cause acute kidney injury. Now, here I mentioned that myeloblast and not typically lymphoblast cause leukostasis in kidney. Why do we mention that? I'm going to mention that in next few slides. So how do myeloblasts cause leukostasis? One, myeloblasts are bigger in size. They are almost 20 to 22 nanometer compared to mature WBCs at around 10 to 12 nanometers in size. Second, they are less malleable, so they have less deformability. And third is they have adjacent molecules. So they express the adjacent molecules which can bind to endothelium by E-selectin ICAM-BCAM. So it can bind to the endothelium and can adhere themselves to the endothelium and cause cytostasis. So that's why myeloblasts, especially blasts, cause leukostasis. Most common organ to be involved in leukostasis and cytostasis is lung and brain. So in lung, patients will develop hypoxemia, and in brain, patients will develop dizziness, confusion, and headache. They are the first signs of cytostasis. And this is again, I go back to the old articles about autopsy articles. So 206 leukemic patients were autopsied in this one, and they were looking for leukostasis in the capillaries from the autopsy finding. And you can see here, in all the patients, only myeloid leukemia patients, AML, CML, have, out of 82, 33 has LTA, which is leukemic thrombi or aggregates, found in their autopsy finding. None of the ALL patients from 39, even if they have blasts, ALL is defined by blasts. Even if they have blasts, they do not develop leukostasis. There is no clear explanation that I can find why myeloid blasts are more adhering to the endothelium, but based on the autopsy study, this is the original finding where everyone says that myeloid blasts are more likely to cause leukostasis than lymphoid blasts. And you can see again, come back to our organ involvement, kidney involvement is very rare compared to lung or brain involvement. Now, we had a patient here that one of the fellow previously wrote. Here we had a patient with very high blast count of 156,000 and was oliguric. We performed leukophoresis and followed by improvement in urine output. Does it mean it was just coincidental? Of course, it's a case report, so it can be coincidental. So we should look at more data, right? So this is a multi-center retrospective study. This is a large retrospective multi-center international study where they used 779 patients with AML with hyperleukocytosis. So all the patients have hyperleukocytosis. Median WBC count is 110,000. Median blast count is 75,000. And these patients, leukophoresis versus no leukophoresis, there was no overall survival benefit. And that suggested that we should not perform leukophoresis in all the patients with hyperleukocytosis. However, if you see the subgroup analysis, if you have leukostasis, so remember, these studies performed on patients with hyperleukocytosis, not with organ involvement of leukostasis. So if clinician has diagnosed the patient with leukostasis, which was almost 27% of these patients, there was suggestion that leukapheresis was possibly beneficial. So authors concluded that it is possible that leukapheresis might improve organ outcomes in selected patients with clinical leukostasis. I think that's all they could conclude out of a retrospective study.
How do you diagnose? What is the definition of leukostasis? How do you diagnose this?
With how would I diagnose? What definition they used in the study? The definition used in the study is clinician oncology team claim patient has leukocytosis.
How do they claim? Based on what?
Clinical judgment.
I know, but what? Let's say
So if you ask me, then I would look at the other symptoms, confusion, which I cannot explain. So let's say my patient, in this patient, if I want to claim this patient has leukostasis in kidney, they should have leukostasis in brain and lung too. So my patient was on 2-liter nasal cannula with completely clear lungs. X-ray is completely clear, and he requires 2 liters oxygen. He has somewhat confusion, and I couldn't explain with uremia. We did the dialysis, but even dialysis, after dialysis, still confused. So the suggestion is this confusion and hypoxemia, which cannot be explained otherwise, are likely from leukostasis. That's all we can claim. There is no biopsy I can do for leukostasis to have objective.
what, checking blood viscosity?
I mean, no, you can do biopsy in kidney for lung and brain. It's a clinical diagnosis.
Well, I mean, because that when you call it clinical diagnosis, you mean that it is not proven, right?
Correct.
As you said,
Clinical
or
suspicion.
other manifestation of other organs.
Correct.
It just not confirms it, but
Correct.
supports it.
Majority of these patients have thrombocytopenia. We saw a couple of cases of renal hemorrhage. So most people are afraid to do biopsy.
Sure.
I think leukapheresis might be safer than doing the biopsy. But again, it's a clinical
Also
judgment.
around
I'm not claiming you
30%.
should or should not.
I didn't even know it's 30%. You're saying 27% of them will have it.
Leukostasis.
Yes.
I'm talking about kidney involvement is
But
exponentially
leukostasis,
rare.
kidney is common.
No, brain and lung are common. So in brain and lung are out of 29,
Okay.
29 patients, 20 had lung involvement, 16, 2 had brain involvement, kidney. Only 3 patients and 2 had kidney involvement.
Is there any gold standard lab test, for example, checking blood viscosity?
Viscosity, yeah. So that's a separate question because hyperviscosity syndrome is a different thing than cytostasis.
But I mean,
Hyperviscosity
it can
syndrome.
cause hyperviscosity, right? If in the setting of leukocytosis.
I'm not sure the test is designed for that. I'll have to get back to you on
Because
that.
otherwise, this is just, I mean,
Yeah.
just
Sure.
playing with words. What is leukocytosis? If you
I
don't have
agree with
any objective.
Every subjective physician can have subjective opinion, correct?
No. What I mean is that it must be some definition of what is the definition? What is the objective definition of leukostasis?
Well, you have to do autopsy. If you can do autopsy, you'll see the.
Autopsy patient is there.
But that will give you a confirmed diagnosis. I mean, you ask me then. You have to, right? I mean, you can do biopsy, but then patient can bleed. So it's a clinical judgment at the end. Okay, coming back to our patients. So the point I was trying to make is blast by default defines the patient with acute leukemia, meaning that you need blasts which are causing the leukostasis. And that's why even if you have 150,000 WBC count with CMML, if they don't have blast, it is very, very, very rare to develop leukostasis. All right. 10 minutes away. Okay. One more disease with myeloproliferative neoplasm. So this group of renal pathologists identified, they published in KI in 2011, that myeloproliferative neoplasms can cause glomerulopathy. If I can find it. So myeloproliferative neoplasm can cause glomerulopathy. What kind of disease are these myeloproliferative neoplasms are causing? They are taking as a group of disease, myeloproliferative neoplasms. So these patients are included as myelofibrosis, polycythemia vera, CMML. They are all included in it. And they are defining the clinical features of these patients. And what I would like to highlight is the findings of chronic TMA and findings of segmental glomerulosclerosis, suggesting FSGS. In these series, they had 11 patients. 8 of them had FSGS. 9 of them had chronic TMA. If we see their proteinuria excretion, many of them have significantly high proteinuria, 13 grams, 3 grams, 14 grams, 12 grams, suggesting they have significant nephrotic syndrome on presentation too. And among the patients who do not have TMA, if you see, there are 2 patients who do not have TMA. Even those patients had close to nephrotic range proteinuria and 3.6 gram proteinuria, even without TMA. So FSGS appears to be one of the features of myeloproliferative neoplasm.
Dr. Shah, are these patients treated with chemo? I just wanted to know if there were any confounding factors that can be contributing.
Before or after, because these are the CMML, these are the patients with CMML, polycythemia vera, coming for biopsy first, and they receive chemo after, which I'm going to talk about next. So these are the different series again, combining from the renal pathology series. There are different clinical reports on it, and what are the type of glomerular disease seen among the patient with myeloproliferative neoplasm. So this case report again, this N of 1, N of 14, some are series, some are case reports. This patient had minimal change disease with complete food process effacement, so that correlates with our patient who had food process effacement. This series has 2 patients with FSGS, 1 with minimal change, and they have 2 patients with FSGS. They received different, this one they didn't disclose. This one has decitabine, hydroxyurea, and prednisone they received, and they had some improvement in kidney function, but then 3 of these patients died. So the one who did not die had some renal function improvement. And these patients received, again, different type of cytoreduction therapy. 1 improved, 2 worsened, 1 continued on dialysis. So variable, again, case reports. So very hard to interpret the data. So in brief, to summarize everything what we talked about today, lysozyme-associated nephropathy, lysozyme stain will be the quick thing to identify that. Leukemic infiltration, CD68 stain will be the quick thing to identify that. Extramedullary hematopoiesis, CD61 stain will be the easy to identify that. Leukostasis is primarily associated with myeloid blast, about 100,000, and myeloproliferative neoplasms can be associated with FSGS minimal change and chronic TMA. This is the very brief summary of the presentation. Third one for Einstein, and this is the last one. All right. So Einstein's equation again said that black holes are not possible. And he wrote an article in 1939 in Annals of Mathematics that Schwarzschild singularities he's mentioning, that's the name of black hole that we recognize now as black hole. Schwarzschild singularities do not exist in physical reality. And guess what? In 2017, we have a picture of black hole. And he did not believe until he died that black holes are even theoretically possible. All right, coming back to our patient. So this was what we saw, mononuclear cell infiltration and diffuse food process effacement in a patient with CMML. So I asked Dr. Zhang, this is happening after months. We requested later because all information we had was patient had leukemia, patient has mononuclear cell infiltration and has diffuse food process effacement. That's the diagnosis he's coming in with. So we requested later that can we look at the lysosomes and lysozymes, not lysozymes, lysosomes. Now, to me, it looked very significant that these patients has a significantly increased number of lysosomes in the proximal tubules. I checked the serum lysozyme level. Normal is up to 2 to 10. It's elevated. So lysozyme level is elevated. The lysosomes are elevated. I asked for lysozyme stain. Initially, I was going to hear no, but he said, fortunately, we have the stain available by chance. So we performed the lysozyme stain in our patient, not positive. It was very trace amount. So that we are not convinced this patient has lysozyme-associated nephropathy. We performed CD68 stain. Again, not strongly positive, only trace amount. So we did not see leukemic infiltration in this patient. So lysozyme stain is negative, CD68 stain is negative. So what did we do for this patient? Of course, we do steroids first, right? So when patient came in to our clinic, we started him on steroids as an outpatient. Now with steroid, creatinine came down very nicely. You can see within 1 month, creatinine is down to close to baseline. However, when I start him on steroid, what happened to WBC? It was 75,000 WBC when I started him. He was 100 and I can't put it in. 140. It was 140,000 WBC when we started him on steroids, of course, right? So then I have to collaborate with a Florida cancer specialist. It's not a Florida patient, UF patient. So he gets started on Vidasa. It is azacitidine, and proteinuria is what I'm interested now, because this patient is dependent on a high dose of 3 milligram BID Bumax, has significant nephrotic syndrome, has 6 gram proteinuria even after starting Vidasa for 2 months. So now we are 2 months out, still nephrotic syndrome, which is persistent, and we try to withdraw steroids, creatinine goes up. So we cannot withdraw steroids, and he continues to have nephrotic and proteinuria. Of course, the number is relatively changing, but the GFR is different at a different time too. Clinically, he's not better. So I give rituximab, again, as we feel fancy. We feel rituximab. So I gave rituximab at that time, and proteinuria now is devoid of nephrotic syndrome. His creatinine is, last creatinine is 2.3, 24-hour urine protein is 2.9 grams, serum albumin increased to 4.3. He does not need any diuretics, and he has no swelling. So his nephrotic syndrome only improved after we gave rituximab. Creatinine improved after we gave steroids. And I'm not sure what happened with CMML, because his WBC count is still going up. Monocyte count is still going up while he's still on Vidasa. His lysozyme level is actually went up on treatment. So there was no correlationship even with the treatment. So my hypothesis is maybe it's the cytokines which is causing FSGS on minimal chain-like disease. Maybe that's the reason because we are treating lymphocytic lineage, and this patient has myeloid lineage leukemia. You're giving myeloid lineage leukemia a lymphocyte-directed therapy with rituximab, which is not traditionally done. There is no case report they have used FSGS or minimal change rituximab. If it is lymphocytic leukemia, threshold is very low because it's lymphocytic lineage. So coming back to our patient, coming back to the talk. In 2012, they defined as MGUS with kidney disease should be called MGRS. Now, because the CMUS was defined in 2022 with clonal monocytosis of undetermined significance, this group of investigators published in KI in 2024, recently in September, that if you have monocytosis with specific kidney disease, we should call it clonal monocytosis of renal disease. But I wanted to highlight the data we have in MGRS is quite different from data we have in CMRS. So maybe it needs a decade or two of work still to clearly every point you guys mentioned about lack of data, lack of definition, lack of clear information on retrospective studies is what's needed to be defined, I think, next 10 or 20 years. And possibly we need to have better therapy because we don't have any monocytic therapy. Like we have plasma cell clone directed therapy, we don't have anti-monocytic cell directed therapy. If you have monoclonal antibody that can target the monocyte, might be much different outcomes. But this is very difficult to interpret right now. That's it. Questions? I think we asked.
Ask a lot of questions during your talk. Really great. Thank you very much.